My name is Rami Komrokji. I'm from Moffitt Cancer Center in Tampa. And as the rest of the speakers, I actually specialize in blood cancers, mainly myelodysplastic syndrome. I would like to thank the MDS Foundation for arranging this. This is a great event. I really, find this audience is probably the best audience to speak to, although it's usually very challenging to speak to. I'm so glad to be here with the rest of the speakers. I don't know if any of you have been to those meetings before, if you attended something similar to this. I don't know how many of you are new diagnosis of MDS. Is there anybody that has a new diagnosis of MDS here in the room today? Like just being diagnosed. So a couple of people there. So, right. So my task will be really giving you overview of the treatment and then what's new on the horizon. This is a big topic, obviously. So I tend to speak fast. Also, slow me down if I was going so fast. But I'll try to give you an overview of all the treatment and what are the exciting new things hopefully coming for treatment of this disease. So I think the management of MDS really starts from the diagnosis, and that's something the other speakers have been trying to stress today. The first and most important step is really establishing the diagnosis for MDS, and I just hinted to the fact that there is sometimes some discrepancy in making the diagnosis, and Dr. Kogel stressed the need or the expertise needed to make the diagnosis for MDS. There was this paper from MD Anderson that looked at the discrepancy between their pathology and the referral pathology, which is usually more a community pathology. And there is like 30% discrepancy, which could be not diagnosing MDS or misclassifying the disease. And in our experience, we see the same. Like I've seen patients labeled with MDS that they had iron deficiency anemia. And I've seen patients that had dysplastic changes that makes a diagnosis for MDS for a year or two, and the pathologist did not call the disease. So establishing the diagnosis is really the right step. And the question, is there a benefit for second opinion, probably stems there. The second important step is really what you heard about, is the risk stratification, because that's not only going to give us the prognostic information, but it does allow us to tailor the treatment somehow, because the way we justify certain treatments we are going to do is dependent on the risk of the disease. We always are trying to make this kind of complex decision between the benefit and the risk for the patient. So what we've been talking about is also this kind of partnership with the community oncologist. In Florida, I think here we have like 4 excellent institutions that can, that have expertise in MDS, but many of them will require you to travel for that. But I see a very nice partnership with the community oncologists where you could seek a second opinion, have the diagnosis reviewed, have the risk stratification reviewed, and then develop a plan of treatment. If that plan of treatment is standard of care approved by the FDA and available, and your local doctor is 5 minutes to home, there is, it's absolutely okay to get that treatment there. But then you could also follow at certain milestones where the decisions need to be made with the referral center. So, and we have this nice partnership relationship with many of the community doctors. So basically, for the goals of the treatment, as you heard about the risk stratification, in general, we divide the patients into 2 groups. One we call higher risk disease, and one we call lower risk disease. And the goals of treatment are going to be based on that. In somebody who's higher risk disease, untreated, you saw that unfortunately, the outcome is not that great. So we really need to do something to try to improve the survival, alter the natural history of the disease, and try to delay the transformation to acute myeloid leukemia because it's higher in patients who had higher risk disease. And the options of treatment we look at include allogeneic stem cell transplant, what we call them hypomethylating agents or azanucleosides. There are 2 drugs approved by the FDA, one called Vidasa, the other one is called Dacogen. And sometimes we talk about chemotherapy. The risk of the disease here is high, so that it may justify taking more intensive treatments like the transplant. While if somebody have a lower risk disease, really, at this point so far, we have no treatments that may impact the natural outcome yet. So what we do is we go by symptoms. If somebody is having symptoms from the low blood count, if they are becoming transfusion dependent, our goal is really to improve their symptoms, improve their quality of life. So we target, for example, transfusion independency as a goal for treatment. And options of treatment currently available include growth factors, which are those injections like the Procrit, Alanesp, lenalidomide or Revlimid, Vidasa, Dacogen, and treatment we call immunosuppressive therapy, where we give certain treatments to suppress the immunity. And I'll talk about that a little bit. So I will start with the higher risk MDS. So if somebody is diagnosed higher risk MDS, typically most of the community oncologists still depend on the IPSS, but as you heard, there is more coming now, the revised IPSS, the MD Anderson sometimes can help us identifying who's a higher risk. Well, the first thing we look at in higher risk, could we do something called allogeneic stem cell transplant? This is a type of transplant where the patient will get the stem cells, the mother cells, of a donor. That donor could be a sibling, or it could be somebody who's volunteering in a large registry that their tissue looks like the patient tissue. The principle with that is that we really replace the immune system for the patient with a new immune system, and when those cells go around and look at the leukemia cells, they recognize them as foreign and they destroy them. And that's the good effect. We call it the graft versus leukemia effect. But the risk with that procedure is that no matter how good is this match, that those cells sometimes will recognize the body as foreign. So they will attack the liver, the skin, and that's called graft versus host disease. So that's the downside or the risk of that procedure. It's really not a surgical procedure. Nowadays, most of the time, they infuse those stem cells like giving blood. They have to give some chemotherapy before. It is an intensive procedure. Patients have to stay in the hospital for like a month, sometimes in an apartment across the hospital for a couple of months after that for intense follow-ups. And for the donor himself, like the donors, they don't really have much risk. So why we talk about transplant? Because this is the only curative option in MDS. Like if we look at something that cures, and cure means down the road the disease is gone, it does not come back at all. There are different terms we use. We use something called remission, that the disease is under check at this point. But cure means that the disease is gone and it's not coming back. So this is the only option that cure MDS. However, it's not a 100% cure. The overall cure rate is 30 to 40%. But the procedure itself is risky, so there is a chance of what we call a transplant-related mortality, death from complications of the treatment in 20 to 30%. So you see that the balance is very fine here between the benefit and the risk for this procedure. As I mentioned, it's an intensive procedure, needs the patients to be in the hospital. There are complications related to the chemotherapy, the infection, that graft versus host disease that I mentioned. So the decision is very complex and should be individualized in general. But for somebody who have higher risk disease, most people agree that the benefit of such a procedure will outweigh the risk of the disease. While in somebody that have lower risk disease, we typically don't advise for stem cell transplant. Historically, we used to do stem cell transplants up to age of 55. Then they started doing what we call the mini transplants or reduced intensity. So they will give less dose chemotherapy before the transplant, and that extended the age of where we can do the transplants to 65. Nowadays, what we say is really that age is function. So if somebody is 70-year-old in good performance, has no other major problems, no heart disease, no diabetes, those could undergo transplant. And somebody who's 55, have like chronic lung disease, may not be able to go through transplant. So really, the transplant requires somebody to be in what we call good performance status and not having any other medical major problems. So they did this, what they call the Markovian model or decision model, to try to predict the benefit. The question is like the best timing of transplant. So if I'm going to consider transplant, when should I consider it? So it turns out, if somebody is what we call lower risk disease, the best gain in survival is if you delay the transplant. Because what I said, patients that have lower risk disease, their survival is measured in many years, and taking that risk of 20 or 30% mortality upfront is not justified. While somebody who's higher risk, the maximum gain for them is really if they consider the transplant early in the course of the disease. So based on this, most people recommend for patients that are called higher risk, if they are eligible to go for transplant, to consider allogeneic stem cell transplant. Now, in spite of that, the reality is that many of the patients with MDS, they are above age of 70. They have other medical problems. Not every patient will have a donor. So when you look at all the MDS patients, even the higher risk, probably only 20% of them will be eligible for something like transplant. So the mainstay nowadays for treating the higher risk patients are medications. We call them hypomethylating agents or azanucleosides. There are 2 drugs approved by the FDA. One is called azacitidine or Vidaza. The other one is called decitabine or Dacogen. There is a little bit slight difference in the mechanism of action. The azacitidine is incorporated in the RNA and DNA, while the decitabine is just in the DNA. What those medications do in a very simple way, what we think they do at least, is you heard a lot about the chromosomes today. The chromosomes are the keepers for our genes. And what happens is that those genes are translated to proteins that they do their function in the cell. So to be able to transcribe those genes to proteins, that chromosome has to open like a book. And when that book is open, then you can translate those to proteins. It turns out that in many cancers, including MDS, there is a process we call it methylation. So if there is a methyl group added to that chromosome, it closes the book and doesn't allow those genes to become proteins. So we call them, they are silenced. And many of those proteins or genes are actually tumor suppressors. They prevent the cancer. So if you silence them, you are giving the cancer a differentiated advantage to proliferate more. So basically, the book is closed and we are not able to transcribe those genes into proteins. What happens with Vidaza or Dacogen, they reverse that methylation. They remove that methyl group, and it allows the book to open and that transcription of those genes to happen again. That's one of the mechanisms. It turns out actually that those also act in a form of low-dose chemotherapy, so they kill some of the MDS cells or leukemia cells as well. But that's the principle how they work. And the reason we use those medications now, standard of care, is this study. We call it the AZA001 that took patients, what we call them higher risk, by the IPSS and randomized them to get azacitidine versus physician choice at that time. The doctor could have done best supportive care, blood transfusions, antibiotics, could have done a treatment called low-dose cytarabine. That's an old chemotherapy. In Europe, they used to use a lot of that chemo. Or even considered intensive chemotherapy like what we do with AML. So they randomized the patients into those 2 arms. And what we learned from this study is actually patients that got azacitidine treatment lived longer. The median survival, that's average, which means 50% of the patients or more were alive by 2 years, compared to 15 months. So the average advantage was almost 9 months in survival. In oncology, that's really a very good milestone or improvement in survival. There are drugs approved in some types of solid tumors like pancreatic cancer that will have 2 weeks or 4 weeks survival advantage. So a median, an average where half of the patients or more had gained 9 months survival is really a good milestone. And this was the first that we established in MDS. So nowadays, we know at least that patients that will get the azacitidine, the average for them, that the median survival is 2 years compared to what you saw numbers when they were untreated that was less than a year or so. So how is this treatment? This treatment, as I mentioned, it's a low-dose chemotherapy. It can be done outpatient, so patients don't have to be in the hospital. It's an injection, can be done under the skin or in the vein. The patient will have to come every day for several days. Typically, in the higher risk, we like to do it 7 days because that's how the original studies were done. It ended that in the community, sometimes it's an issue over the weekend where many of the cancer centers are not open. So they do this Monday to Friday, they break for the weekend, and then they do Monday to Tuesday. But 7 days is what most people agree that is the appropriate dose in the higher risk. In general, it's well tolerated. It does not cause hair loss like the intensive chemotherapy. Patients will get nausea, and if they have to take a pill for the nausea before the treatment. It can decrease the blood counts. So I always tell the patients in the first couple of months, actually, your need for blood transfusions and your counts could look worse, and that's expected. Usually, the treatment will kick in the 3rd or 4th month, and then that's when we start seeing improvement. And then the other thing we can get sometimes as a side effect is constipation. And if the treatments are given under the skin, sometimes there will be like an injection site reaction. But in general, compared to intensive chemotherapy, this is very well tolerated. We treat patients in their 90s with this treatment, and they are functional. Patients could still go to work with this type of treatment. So what is the new paradigm with this treatment? We know that this treatment now extends the survival. It does alter the natural history of the disease. We know that you don't have to go into complete remission with this treatment to drive benefit. So somebody who's on azacitidine treatment and their counts are improving, we know that actually those patients will drive survival advantage. So we don't have even to be in complete remission. Just having your blood counts improve with this treatment will actually translate to what we call a survival advantage. The other thing we need to know is we have to continue those treatments. Unfortunately, many times those treatments are not continued. And the response will be lost. So those treatments will not work forever anyhow. On average, patients will stay on them for a year, year and a half. Then the MDS cells become resistant, and the response will be lost eventually. So when patients have a response, it's very important to continue on treatment, not stop the treatment. And first responses actually can take some time. Most of the time, they happen by the 3rd or 4th month, but sometimes it may take up to 6 or 9 months. So sometimes the doctors, you'll see that they will repeat a bone marrow after 4 to 6 treatments. We call the cycle, a cycle is a month. So you get a week of the treatment, 3 weeks of the treatment, that's called the cycle. So after 4 or 6 of them, they will repeat the bone marrow and the tests. If things looked what we call them stable, not better, not worse, they may tell you to continue a little bit on this treatment. Typically after 6 to 9 months, if there is no response by any means, then the benefit of those treatments diminishes and one would look for other alternatives. So if the blood counts improve with the azacitidine treatment, then it's probably going to extend the survival and prognosis. Responding patients should stay on treatment. And typically, we look at 4 or 6 months out of the treatment to decide on if the treatment is working or not. So this is kind of summary of what we do nowadays with the higher risk. So if we see somebody with higher risk MDS, we ask ourselves, is the patient candidate for allogeneic stem cell transplant? They don't have other medical problems, they are in good shape, and is there a donor available? Sometimes, even if we are interested in transplant, if we say, yes, we want to go to transplant today, that process takes 3 to 4 months. It takes, on average, a month or 2 to identify a donor if the siblings are not. And it has to be either a sibling or a donor in the registry. So kids will not work because they only have half of your genes. They don't have the full chromosomes of the parents. So meanwhile, most of the time, we will start the patients on those medications like azacitidine or decitabine till we get to the transplant. If there is no donor, then the standard of care is those medications nowadays, the azacitidine or decitabine. And if they stop working, then the next thing we look at is clinical trial. How about the lower risk? So this is the higher risk. And in higher risk, I think most experts will agree that patients, if they are in higher risk, they will need treatment regardless of their symptoms because the disease is risky enough that you need to try to alter that natural course of the disease. Now, if we talk about the lower risk disease, this usually manifests with cytopenia, has low blood counts. Most commonly, in 80% of the cases, this is going to be anemia. But sometimes it could be low neutrophils, so patient will be at risk of infection. Sometimes it could be low platelets, so you'll be at risk of bleeding. So the goal of treatment here is really to improve the blood counts and the related symptoms. If somebody is anemic, his hemoglobin is 7, he's going to feel that. He's going to be short of breath, tired, not able to do anything around. If somebody's platelets are very low, they will bleed. So we treat for those symptoms. At this point, there is really no data that shows us that if we do treatments earlier, if somebody is asymptomatic, let's say somebody is diagnosed with MDS, their hemoglobin is like 10.5 or 11. Most of the time, that's an adequate number that patients will not be feeling it. There is no evidence that if we treat earlier, that will make a difference. However, I think Dr. Foran may indicated that we are trying to look with all those new models. Is there a group of patients that have higher risk features that will benefit from early treatment? So that's kind of a work in progress. But in general, the agreement that if somebody's counts are adequate, then there is no indication for treating them. So we treat when there are symptoms or when patients get to transfusion dependency if they are needing blood. Typically, patients start needing blood every month or two, but that could escalate that some patients need blood transfusions every 2 weeks, or sometimes on a weekly basis. And there are different options for treatment in the lower risk. So again, most of the time we will be treating anemia. And one of the first steps we could use are those what we call them growth factors. There is a hormone called erythropoietin. This hormone is actually naturally produced by the kidney, and it goes and stimulates the bone marrow, the factory, to produce the red blood cells. And there are two forms available of it commercially. One is called Procrit, that has to be given on every week, and one is called Aranesp, that can be given every 2 weeks or sometimes every 3 weeks. They are similar. One is just long-acting. The other one is short-acting. So most of the time, this could be the first step of treatment the doctor is talking about. It's very helpful if it's applied early in the disease. Somebody is not getting so many units of blood transfusion. If somebody is coming and getting 4 or 6 units every month, the likelihood of such treatment to work is very low. And we also check the endogenous level. We check how much the body is producing from this erythropoietin. So if the endogenous level is high, is more than 500, the chances of responding to the superdose from outside is really going to be low. So sometimes we will skip that. But if somebody have low level of that erythropoietin in the blood, and they are early in their course of the disease, they are not getting transfusions, there is around like 40%, 30 to 40% chance of responding. Their counts will improve. They will avoid blood transfusions. And if they responded, they could respond sometimes between a year or 2 to those injections, which relatively don't have much side effects. Now, you could read that the FDA actually issued some safety warnings about those medications in patients with solid tumors, in lung cancer, breast cancer. They used to do those concomitantly with chemotherapy, and they tried to push the doses, the level of the hemoglobin with them. So there were some risks there. None of those risks actually apply to the MDS patients. So there is no data to suggest that those injections, the Procrit or Aranesp, will carry any risk for the MDS patients. Sometimes your doctor will use other type of injection. It's called Neupogen or Neulasta. Those are factors that stimulate the white blood cells and neutrophils to go high. In general, actually, there is no role for those. Like, if somebody's neutrophils are low and you give injections to keep their counts high most of the time, studies have not shown that there is a difference. They could sometimes be handy if somebody is having an infection, comes in with pneumonia, having fever, the counts are low, so transiently they could be used. But a chronic use of those injections that increase the white blood cells had not been shown to be actually beneficial for patients. All right, so usually that Procrit or Aranesp is the first step. If it did not work, or if the chances of that treatment not working is not high, then usually we go to the next step. So usually we ask ourselves the first question: does the patient have this chromosome abnormality you heard about? It's called 5q deletion. So part of the chromosome 5 is chipped out, and it turns out this is the commonest abnormality in MDS, although still it's like around probably 10 to 20% of the cases. So if the patients are lower risk and have this abnormality, the standard of care is this medication called Lyridomide or Revlimid. This is derivative of other medication was known in the past called thalidomide. In the 60s, it was associated with all those babies born with anomalies, and it turned out that actually it inhibits new blood vessel formation. Then they started studying it in cancers, and the Revlimid is derivative. It has different toxicity or side effect profile. It doesn't cause numbness. It can decrease the blood counts, but it's very effective in patients that have the deletion 5q, especially that if their other counts, like the platelets and neutrophils, are good. This is a pill the patient will take on daily basis, and with this pill in the deletion 5q, around 2/3 of the patients will become transfusion independent completely. And around half of them, when we look back at their bone marrows, we will not be able even to see that deletion 5q. So they get into what we call cytogenetic response. When we look at the average increase in the hemoglobin with those studies, it's around 5.4 grams. So somebody could start with hemoglobin of 8, and then they will be running around 13. And we call the responses durable. So when they respond, patients on average respond somewhere around 3 years. They will not need any blood transfusions. And the time to response is relatively short. Within 1 or 2 months, we will know if they are responding or not. the main side effect for those medications, especially at the beginning, that they could also lower the blood counts, similar to the story with azacitidine. So what I tell all the patients that in the first 8 weeks of the treatment, you are going to get blood counts checked every week. And there is a very high likelihood that we will call you and tell you to stop the treatment because the counts will go down. But with the deletion 5q, that's actually a predictor of response. So somebody who's dropping his count, we know that in a way we are wiping the bad cells and we are just waiting for the good cells to recover. So we try to support the patient with, if needed, transfusions, antibiotics. We stop the treatment. And when the counts recover, we start at a lower dose of the medication and then we continue. Other than the low blood counts, some patients could have rash, diarrhea, itching. But in general, again, this treatment is relatively well tolerated. Now, so I think everybody now accepts that this Revlimid or lenalidomide is the treatment of choice for patients with deletion 5q. But as I mentioned, deletion 5q is only like 10% probably of the patients. So how about the majority of the lower risk patients that have no deletion 5q? They could have normal chromosomes or other chromosomes. It does work, but it does not work as good as with deletion 5q. So only 1 out of 4 patients will get transfusion independent. And if they worked, they work in general for around a year and they stop working. So it is still one of the options if we are treating purely anemia, but it's not as good, effective as in patients that have the deletion 5q. But nevertheless, it's still one of the options because as you are hearing, the options we have are in a way limited. The growth factors, the Revlimid, and the hypomethylating agents. Like we almost only have 3 medications approved now for this disease. So azacitidine that I talked about in the higher risk is also very effective treatment in the lower risk. So patients in the lower risk could get the azacitidine and their counts could improve and they become transfusion independent. And in fact, if somebody have low platelets, that's the treatment of choice for patients with low platelets. That's the only medication that will improve their platelets. In the lower risk, we've learned from this study that actually you don't have to do the 7 days, that probably 5 days in the lower risk is as good, where almost half of the patients will get a response, and the side effects are actually less. So a schedule of Monday to Friday injection, so you get them over a week, and then you get 3 weeks off, and then you go back and do the treatment, is effective. And this treatment is effective for reducing the blood transfusions and improving the blood counts in the lower risk. We probably had touched base a little bit earlier on this. There is a subset of patients with MDS that there is really immune deregulation in those patients that can contribute to the disease. So in addition to the clones that you heard about, those are triggering the immune system. The immune system thinks that those are foreign and they attack them. But when they attack the bone marrow, they attack the whole bone marrow and can cause the blood counts to be low. So we say that those patients have like an immune component of their disease. And if we suppress the immunity, maybe we'll be able to improve their counts. Typically, this is in the early risk of the disease. This is not a treatment that can be applied for the higher risk disease. So we look at variables like who would respond to such treatment. What we do is we give treatment called ATG, Antithymocyte Globulin. This is like an antibody that blocks the T lymphocytes. Those are the lymphocytes in our body that attack the bone marrow. And actually, this could be derived either from horse serum or rabbit serum. It's one course given in the hospital for 5 days. Sometimes we give another pill called cyclosporin with it that decreases the immune system. And, several groups had tried to look at who are the patients who will benefit from this treatment. And, we look at different variables, younger patients. If their bone marrow is called hypocellular, we mentioned this, Dr. Kogel, I think, mentioned this earlier. Sometimes there is a group where aplastic anemia and MDS, kind of a gray zone between them. What the NIH looked at those variables, they came out that the most 3 important variables to predict response to this immunosuppressive therapy is age. So patients actually have to be younger, less than 60. They have to have short duration of transfusion, typically less than 2 years having the disease. And there is a tissue marker that we can test called HLA-DR15. If that's positive, they have higher chances of response. So a very small subset of patients with MDS, if they are younger than 60, they've tried the Procrit or Naranasp and it's not working, this treatment could be a beneficial treatment for them. If you select patients correctly, almost 2/3 will respond, get a course of 5 days, and they may have 2 or 3 years improvement in their count. Above age of 60, the chances of response really drop significantly, so that's most of the time why physicians don't bring this type of treatment. And this is type of treatment that probably cannot be done in community practices. This is need more an academic center specialized for such infusions. So this is currently how we look at, how we manage the anemia in the lower risk. So again, in the lower risk, we are going to go after symptoms. If somebody is needing blood transfusions, their blood counts are low, we are going to go after that. If the neutrophils are low, there is really not many treatments that are effective for the neutrophils. If the platelets are low, we go with the azacitidine. But most of the patients, when we are treating for anemia. So the first step we look at, we say, what is the endogenous erythropoietin level? If that's low, then we give those injections, the erythropoietin, Procrit or Aranesp. If it stopped working, then we could consider either azacitidine, or if the patients obviously have deletion 5q, the treatment of choice is Revlimid. In a small subset of patients, if they are less than 60, then we consider that treatment the immunosuppressive therapy that I talked about. An important aspect also in the management that we've learned about in the recent years is what we call iron overload. So you saw from Dr. Foran a slide that showed you that patients that are transfusion dependent, they don't do as well. So if somebody is getting regular blood transfusions versus somebody not getting blood transfusion on regular basis, there is difference in the outcome. Part of this is the underlying biology that Dr. Kogel spoke about, that patients that have worse disease will probably need more transfusions. But it ended that part of this, that with frequent blood transfusions, we build so much iron in our body. The body does not have a mechanism to get rid of the iron. So each unit of blood we get has almost like 250 milligrams of iron. And it's estimated that once you get around 20 units of blood transfusions, you are in that state of iron overload. The doctors could use different tests to measure iron overload. The best way is actually getting a liver biopsy, which is an invasive procedure, and an MDS has its own risk, so we don't do it. Most of the time, we depend on a test called serum ferritin. That's a blood test the doctor can check. It's not the best because it can sometimes be high if there is inflammation or infection, but nonetheless, most people use this as the marker for the excess iron. So what happens if you have excess iron? It can cause damage to different organs. It can cause damage to heart, so patients will develop heart failure. It will cause damage to the liver. It can cause damage to the pancreas, so patients will become diabetic, and other organs. And we know about this a lot in patients that, children that have diseases like thalassemia or sickle cell, that they need blood transfusions on long term. We see, unfortunately, many of those sequelae of the complications of the iron overload. So, I'm sorry, this is not showing very well. There should be two figures here. But what they looked at, if patients have a high serum ferritin, that test is more than 1,000, actually their outcome was worse. And their chances even to go to leukemia was higher. And several studies so far had suggested that if the doctors use medications, we call them iron chelation medications, they get rid of the excess iron, that the patient's actually survival will be better. This is mainly restricted for patients with lower risk or if patients are going to transplant. So the national guidelines like the MDS Foundation or the NCCN recommend considering iron chelation for patients that have had several units of blood transfusion, that their serum ferritin is high. There is a role nowadays for iron chelation. There are 3 available agents currently. Defruxamine is an injection. It's a pump. The patient has to have a pump all the time there. So many patients don't like that. But it's the oldest form of iron chelation available. There is a medication called Defrasirox or Xjade. That's an oral. And recently there had been another medication brought on, Defriprone, which is another oral medication. There is difference in the side effects here. This can cause sometimes neutropenia. The Defrasirox can cause renal damage or GI symptoms. So they do have side effects, and one has to weigh the benefit and the risk. But in general, I think iron chelation is now accepted as part of the management for the lower risk MDS. All right, I think I'm going to stop here. Is there any question before I go into the second part of the talk? Go ahead, please.
For patients who are anemic with MDS but have not been transfused or anything like that, should they be supplementing iron?
Probably not, unless, we were talking about that actually yesterday. I've rarely seen patients that have MDS that have concomitant iron deficiency. And you could tell that by looking at the bone marrow. There's something they call checking the iron stores or those serum ferritin. So rarely if somebody had like a bleed in addition to the MDS and they depleted their iron, they will respond. Most of the time, we do those iron replacements as a reflex, actually, because if somebody's anemic, we try B12, we try iron. In general, they are not helpful. So neither B12, folate, or iron will help MDS per se. But if it was that rare occasion where there is iron deficiency and MDS, then yes. Sometimes if patients had been on Procrit for a long time, Procrit uses the iron kind of fuel to increase the blood cells. So you could get into iron deficiency from long-term use of Procrit. That sometimes could help. But for MDS per se, no. If the patient is getting blood, that could obviously be detrimental because he's already iron overloaded and you are increasing the problem.
Okay, so if somebody becomes progressively anemic and they don't want to start getting transfusions, they can look into Procrit?
That probably will be one step. As I mentioned, you have to look at if they are not getting transfusions, that's one criteria because the less the transfusions, the higher the chances of response. Then the other thing, you check their endogenous level of that Procrit, the erythropoietin. If their serum level is below 500, it's worth trying it. We typically try it for a couple of months. If they respond, then you continue. If they did not respond, then you think of moving to the next step.
Oh, thank you.
Go ahead, please.
Has there been any research done on the long-term effects, which I know has only been 6 years with XJ? It's been in existence for 6 years.
Right, so there is no long-term effect. And that's an excellent question because the data I showed you on the impact of the iron chelation really were like prospective study following patients getting different forms of iron chelation. The studies that were done with XJ in MDS, their end point, what were they looking at? Do we lower the iron or not? They did not look at survival. So we don't know that effect for sure. We know they are very effective in decreasing the iron. And I think everybody believes that if you decrease the excess iron, you are going to improve survival. But there has been no randomized clinical trial like the one I showed you with azacitidine that document that. There is an ongoing study. The company that makes XJ, Novartis, has been trying to do this randomized study, but it's not been very easy to put patients on because patients go on and receive so many other medications. But I think most experts in the field think if you are lower risk and you have excess iron, that iron chelation will benefit. Like we looked at our experience in the lower risk, we see the same survival advantage. There are like several groups now reported in their experience, and on the long term, they see a survival advantage. In terms of long-term side effects for the XJ, all those medications sometimes can cause hearing damage. So sometimes we do like audiometry on long term to make sure there is no hearing damage. They can affect the kidney function. So at the beginning, we look at the kidney functions. But I'm not aware of a long-term effects for those, like a detrimental effect for long-term use of those medications.
Is the liver and the kidneys being affected also by desferol?
To less extent, I think the renal damage is less with the desferal. But with the desferal, you could get more hearing loss, hearing damage. So. Go ahead, Chris.
Rami, I have a question. I've been meaning to ask you. If a patient is on Vidaza or Revlimid for a while, and then their blood counts start going down, do you ever check EPO levels? Is there any role for checking EPO levels? And I seem to remember you guys presenting that before, and I don't know the details.
Right. I'm going to actually show some slides on that Rev-EPO combination. So I'm aware of that. With Revlimid, sometimes we see that augmentation of the response. With the azacitidine, I don't know. The French group had published on AZA-EPO combination up front, and they claimed that or what they showed in their study, that actually showed better responses and even potentially survival advantage of the combination of AZA-EPO. But we've not done it in that way. We do it with the Lyridomide, and I'll show you in a minute some of that. So. All right, so in the second part, I'm going to try to focus on where we are moving. I think this is an exciting time for us that work in this disease, that there is a lot of things that we've learned, thanks to work of people like Dr. Naimer and others. We've made so many discoveries about the mutations, the mechanism of this disease, the biology, and now that's translating to better understanding of the disease, better reflection of the prognosis for the patients, but also having what we learn about as biology of the disease becoming as targets we go after with newer treatments to try to improve the outcome. The azacitidine was really a very important milestone for us treating patients with MDS. It was the first drug that improved the survival. The Revlimid is an excellent option, but we definitely have a lot of unmet needs that we need to keep working on. What I'm going to be showing you here is probably a little bit biased because it may reflect somewhat of what we are doing, or it's my flavor of things going on. It's not a comprehensive it's impossible to tell you all the advances or what every group is doing, but it just gives you a flavor of what's going on, where the field is going. So in general, the development, the goals of treatment or where the field is going is first trying to better select the treatment for patient. So trying to know who's going to be better responding to Revlimid upfront rather than trying Revlimid, looking at certain markers or tests and saying, yes, this patient will have a very high chance of using Revlimid as a treatment response, so I will go with Revlimid rather than Vidaza. So we call that better patient selection based on biomarkers or tests. The other thing, now as we have Revlimid in deletion 5q is established, we are starting to see sometimes patients after 3 or 4 years, the Revlimid stops working. So we are trying to understand why is that happening, can we overcome that? Other strategy is like I showed you that in the non-deletion 5q, Revlimid does work, but it's not as good as in the deletion 5q. So we are trying to look at strategies, can we improve that? We are trying to bring new medications. If those old medications stopped working, and there is a point that all those medications stop working, then we try to bring newer medications. The azacitidine is a very important treatment. We are looking at strategies, could we improve that response? Make higher number of patients respond, or longer duration of response. So I told you the average duration of response to azacitidine is like 1.5 years. Could we make that 2 years or 3 years? Could we make 70–80% of the patients respond to azacitidine by combining it with something else? A very important area and open area for research now is like what to do after azacitidine in the higher risk. So if patients are not going to transplant, azacitidine worked, now it stopped working, what is next? And that's a very active area in research. There are limited agents that are used for thrombocytopenia, and there are new medications being tested to treat thrombocytopenia. So on the principle of selecting who's going to respond better, there is this mutation that had been described, I think now several years, called Tet2 mutation, that actually has some prognostic information. But if patients have this mutation, they may actually have a higher response to azacitidine. So down the road, it's not yet commercially available to be tested, but down the road, we may come and say, okay, we have those two options. If the patient have this Tet2 mutation, they could probably will have higher chance of response to azacitidine. Let's go with that. As of today, that's not available. Academic centers like our place and the other speakers' places probably could do those tests, but they are not yet available into a certified labs that they could translate that into a clinical practice. Another effort like that is sometimes we have those, what we call them gene expression profiles. We could look at thousands of genes and see what they are doing, and we call them signatures or like heat maps, which gene is overexpressed or underexpressed in disease. And it turns out that sometimes there is a certain signature of the disease by the genes that you can realize. If it is there, you have better chance to respond. This is actually reality in breast cancer. They do something, they call it, I think, OncoScore or Oncotype, that if the patients have a certain score based on that gene signature, then they benefit from chemotherapy. They are trying to do the same with Revlimid. There was this study by Dr. Ebert that suggested that if certain genes are underregulated or underexpressed, and you have that signature, your chances of response to treatment are higher. So they are trying to validate that in a clinical trial now, and that in the future could become something like the Oncotype used in breast cancer, that we will look at this and say, yes, this patient have the signature that's appropriate for the Revlimid, let's go with Revlimid treatment. Now, in the deletion 5q, some of the work has been trying to understand the disease. There had been several discoveries in the deletion 5q, although it's a very it's only 10% of the MDS patients, but it's a very unique model because you have that loss of the 5q chromosome. You know what genes are there. We figured out which gene, if it's hit, that leads to the development of the phenotype of the MDS. And then we figured that the Revlimid targets certain genes in that area. And what we've learned that part of the Revlimid work is through a protein called P53. This is like a break on the cell cycle. And usually, what happens in MDS, in the deletion 5q, the breaks are overexpressed in the red blood cells. So the red blood cells are not allowed to further develop, or they are arrested in development. And what we see is usually that the P53 is increased in patients with deletion 5q. When we do treatment, they go down. but when they are becoming resistant to treatment, it goes up substantially. So this is part of how they become resistant to the treatment. And as we understand that, we are trying to develop treatments to overcome that. One has to be careful because this p53 also could regulate, the tumor cells. You don't want sometimes to suppress too much to p53 because you could also make the disease worse. So it's a very fine balance. But as we understand the mechanism, the biology of the deletion 5q and the underlying mechanism for resistance, we could target some of those. For example, we could target the p53 with a medication called Senersen. It's a small piece of the DNA that can bind the DNA and prevent its production, so it will decrease the p53. Or sometimes with something simple like just adding steroids, dexamethasone to lenalidomide, we've had some patients that when we add that, we actually gain back the response. This is all still early in development, but it's just the concept that once we understand the reason for resistance, we could go after that. This Senersen is a study that we are going to go and explore as a phase 1. So it will be early phase, just if a proof of concept, principle. If we decrease that p53, the breaks, can we restore the erythropoiesis in patients with deletion 5q that had become resistant to Revlimid? Now, as I mentioned, lenalidomide in the non-deletion 5q is still going clinical trials. This is a trial that looks at Revlimid versus placebo in the non-deletion 5q. But within this trial is that gene expression profile where they are trying to validate to see if we can use that signature in the future to decide who's going to respond to Revlimid or not. Another effort is what Dr. Kogel just alluded to is, could we sometimes combine those medications? Or like if you do EPO with Revlimid, is there a benefit? We just published on a study we did where we treated almost 40 patients. Those patients had deletion, some of them had deletion 5q, but majority had non-deletion 5q. They had Procrit or Aranesp. They responded or did not respond. Then they went to get Revlimid alone. And if they did not respond, we combined both of them together with the idea that they could potentiate each other effect. And in around 20% of the patients, 15 to 20% of the patients, we got a response back. So that study was kind of a proof of principle. Now this is an intergroup study. So all the National Cancer Institute groups are participating in that study where patients are randomized between lenalidomide and lenalidomide erythropoietin to see if the combination will get us larger responses. So sometimes in my practice, if I see the EPO going down, I would add, or if I see the response to lenalidomide starting to go away, I will add EPO. And I've seen sometimes we gain the response back in some patients based on that. I think I omitted the other slide, but another effort we are trying to do is we are trying actually to combine Lyridomide and Prednisone. This is a study that me and Dr. Kogel doing together. There are some preclinical data suggest that steroids actually could potentiate the effect of lenalidomide, so we are combining them, and this study is available at Shands and at Moffitt. So again, the idea is like trying to do some combinations with the available treatment to improve the outcome. The azacitidine, you heard a lot about it. Actually, the company that makes azacitidine is developing an oral azacitidine now that will be much more convenient to use. And it could be that it has actually different effect or better effect because it's administered on more continuous basis. In fact, in the first round they presented, there were patients that did not respond to the sub-Q or IV azacitidine that responded to the oral azacitidine. So this is now moving into the lower risk disease. There is a randomized clinical trial that's going to start. And they are also using this as a strategy in acute leukemia and after transplant. So if somebody goes into remission, try to prolong or keep the disease under remission longer. It's much more appealing for the patients, obviously, to take a pill at home rather than coming 7 days in a row every day to the doctor's office to get an injection. Another drug, so this is one part. So the part I talked about is either try to select patients for the patients that have better chance of response, try to do combinations with available treatments. This is all in the lower risk. Then the other strategy is to try to bring new medications. For example, this drug called TLK or Terentra, it inhibits certain enzyme that will actually promote the erythropoiesis if you inhibit that. And in single agent studies, it had some activity, but it looked also that in combination with lenalidomide, it may have better outcome. So now there is move to move this into a phase 2. Like typically when we do clinical trials, phase 1 is to establish the safety. So we test the drug in a restricted number of patients. We put like 3 patients on the study. We look for the side effects. If there is no side effects, we put another 3 patients. And all our concern is really to make sure that this treatment is safe for the patient. Once we establish that, and if we see that there is some hint that this treatment is going to be active, we go into what we call it a phase 2. In a phase 2, we try to see the efficacy of the treatment. So every patient on a phase 2 will get the treatment, or in majority of the cases. And if it looked that we treated 40 patients, and yes, this is going to be working in 30 or 40%, then we move to what we call a phase 3, where half of the patients will be randomized to get the treatment, or the new treatment versus the current available treatment. And that's kind of the gold standard way to get a treatment approved by the FDA to become available.
Does the FDA approve all the various steps you go through? Or
Right.
is that up to the center?
They have to review them, and there are pathways, they call them registration. So like even a phase 1, if it's the first time using the drug in a disease, there have to be discussion with the FDA. They sometimes have some mandates on what to look at for safety. And if the drug is further developed, then it goes into a registration strategy where the FDA actually will dictate a lot of the design of the clinical study, the outcome, in discussion with the investigators. All right. Another medication that we are testing is a drug from a company called Array Biopharma. It's called Array 614. This is a medication that blocks the inflammatory pathways. So in the lower risk MDS, there is a group of patients that actually there is like this chronic inflammation in the bone marrow. And then sometimes if you shut that down, you could improve their counts. We tested this in a phase 1 where we had almost 40 patients. And in fact, we saw responses in almost 1/3 of the patients. And that sounds encouraging because usually in a phase 1, we don't see those higher responses. So we had better formula of the drug now that we are testing, and this is going to move into a randomized registration study, actually. The appeal of this drug is that it also can improve neutrophils and platelets, not just the red blood cells. Another pathway that we learned about is called TGF-beta signaling, transforming growth factor. This is a pathway that ended to be overexpressed in MDS. And there is a medication that inhibits a part of that pathway, a receptor called activin. The drug is called sotatercept. The story developing this drug is interesting. This drug was, activin pathway is also important in preventing osteoporosis or bone weakness. So the first where the company went with this drug was originally in women. Actually, they were testing it in healthy women to see if they can, treat bone weakness or improve on bone osteoporosis. And the dose-limiting toxicity, the main side effect that was seen, that patients' hemoglobin went up very high. So we call it erythrocytosis. The red blood cells increased. Till now, we don't know exactly how the inhibition of this pathway will promote the red blood cell production, but that was the main side effect of this drug. So in MDS, we said this is a welcome side effect. We want to bring this drug into MDS and test it. And this is going to be now a multi-center study where we are going to test 3 doses of the sotatercept. We just heard back from the FDA actually on some criteria they wanted us to put on the study. And in a month or 2, hopefully we'll have the study open. And it's an injection that is given every 3 weeks. Probably this is going to be similar to the Procrit RNS principles that patients come and get injection. It's mainly for anemia. There is another medication we are bringing from a company called Incyte. This drug inhibits an enzyme called endolamine deoxygenase. This enzyme actually is important in metabolism of amino acid called tryptophan, but it turns that also it can have some effect on the immune system. It can modulate cells called myeloid-derived stem cells. I think Dr. Kogel alluded a little bit sometimes that the bone marrow itself, the microenvironment is the abnormal, and this is an example of that those cells are usually expanded in MDS, and they actually can cause the blood counts to be low. So we are hoping that this drug inhibits this enzyme and maybe alter that immune deregulation because the IDO tends to be overexpressed, not just in MDS actually, but in other type of cancers. We just submitted this study to be open and activated, so hopefully in a few months we'll have that study open as well. So this was mostly in lower risk. How about the higher risk, where we said azacitidine is the standard treatment? One effort had been actually pioneered by Dr. Sikiras at the Cleveland Clinic, is just combining the Revlimid and azacitidine. So how about if we do both of them? Both drugs are active. And in fact, the phase 1, phase 2 studies showed very encouraging results that around 42% of the patients had a complete remission to the combination. When we do azacitidine alone, the complete remission rates are usually less than 15%. So this, as a phase 2 study, looks an appealing combination. The other combination that was tested is azacitidine with a drug called Vorinostat, or it's commercially approved by the FDA for a disease called cutaneous T-cell lymphoma, another type of blood cancer where patients will have lymphoma in the skin. But this drug also works in modulation of the chromosome for the same process I told you about, like to open the chromosome. And the combination also together seems appealing, where some patients have a response. So based on those phase 2 studies now, there is an intergroup study. Those studies, when they become intergroup, are sponsored by the NCI, and several centers will have them actually in the country. So there is this study that will take patients if they are higher risk, newly diagnosed, treat them with the standard of care, which is azacitidine, versus azacitidine plus Revlimid, versus azacitidine plus Vorinostat, and then we will be able to tell if there is a winner here. And if it turns out that this combination either gives us higher responses or longer duration, that may change the practice or the standard of care down the road. But we don't know the answer, and that's why we do clinical trials, because it may turn out that still doing azacitidine alone is the best way. But it's a very good study, and hopefully will answer an important question for patients. As I mentioned, an area that is really kind of wide open for research is what to do after nucleoside failures. After this azacitidine or decitabine failed, we and our group and other groups had looked at the outcome, and unfortunately, once those treatments stop working, the outcome is not great. So we definitely need to do things to improve the outcome. And actually, when the French group published, the best outcome for patients after azacitidine were the patients that went to clinical trials or to transplant, not got just any other like intensive chemotherapy. So what we try to do is we try to see if the patients are eligible for transplant, but if not, I think this is a very active area in clinical research, and that's where there is really definitely an unmet need for patients nowadays. So there are several treatments. Each center has a compound or two they are testing. You heard about the promising treatment that Dr. Kogel has. Other centers had different treatments. A drug that is going into a randomized phase 3, which means a registration, that if the study becomes positive, it will be approved, is called Regisertib or Onconova. This drug can be given infusion or oral. The study that's available now is actually the infusion. It requires a pump for the patient, but it's available in many centers. This was tested previously, and the treatment had been shown to decrease the leukemia cells or the blasts. We tested the oral form. Several other groups had tested the IV form, and all had shown that it decreases the blasts. So now there is a multi-center study that is comparing this treatment compared to what we will call best supportive care, either low-dose cytarabine chemotherapy or blood transfusions and so forth. If this study turns to be positive that the patient drive survival advantage, then this could potentially become an approved treatment for the disease. Another drug that's been tested, it was going to go into phase 3, but now it's going to slow down a little bit, is Acidostat. This actually medication inhibits a enzyme called aminopeptidase. So it inhibits some of the amino acid metabolism within the MDS cells. And in earlier phases in AML and MDS, it looked that there are some responses. So we are going to move with testing this in what we call a phase 2. So there will be a group of 30 or 40 patients that will get the treatment. And if we see enough signal, then maybe it will go into a phase 3. Oral chlorofarabine is a chemotherapy that's been tested in several times. It is active. It has around 30%. Now the move with this is to test a oral dose, a very low dose of the oral chlorofarabine for patients. So there are some studies that will be coming with the oral chlorofarabine in a low dose fashion. The drug is approved actually IV by the FDA for acute lymphocytic leukemia in children. So it's it has other uses as well. For patients that have severe thrombocytopenia, as I mentioned, the only option for them is azacitidine or Vidaza. Other than that, there are no approved options that can improve the platelets. There are 2 drugs approved by the FDA for other diseases, Romiplastim or Eltrombopag. They are approved for a disease called immune thrombocytopenia. Both were undergoing clinical trials. The Romiplastim trial was actually stopped because there was some concern that it can increase the leukemia cells. So unless this was in a clinical trial, we usually don't advocate to try to do those things outside the clinical study. We've been testing the Eltrombopag. We tested the Eltrombopag in the higher risk MDS, and we're actually not seeing much benefit, so we probably are going to close the study. In the lower risk, the French group has been testing this drug, and they are seeing that it could be effective in helping increasing the platelets, but this is still early. So if it's going to be done, we always recommend doing it on clinical trial, not trying something outside a clinical trial, because sometimes we want to avoid any harmful side effects for the patients that we don't know about. So we don't try to use things outside the clinical trial unless we see some evidence that they will be effective. There are other agents also that will be brought to try to improve the platelets. So then with intensive chemotherapy, actually, there are a subset of patients that will have MDS, get azacitidine, but unfortunately, 1/3 of the patients will go to leukemia. And what we've learned recently that the standard chemotherapy that we've done many years for the AML, called 3+7 intensive chemotherapy, it does work, but it does work much less in patients that come from MDS to AML. So our group had been trying to use a little bit more intense chemotherapy. We use a regimen called CLAG-M. Other centers try to bring clinical trials to use different intensive chemotherapy to improve the outcome, because the standard doesn't seem to be as effective after azacitidine stops working in this group of patients. So basically, I just tried to give you a flavor. This is some of the studies that we have. We have 2 studies with the Revlimid upfront, Revlimid Procrit, Revlimid Prednisone, along with Dr. Kogel. We have the Array 614. The Sept is going to be coming. In the higher risk, we have a study where we have a vaccine. Actually, we try to boost the immune system in addition to the Revlimid. We have another monoclonal antibody. So different strategies, and each center will actually have their own flavor of those clinical trials, trying to bring new treatments for patients. But obviously, we are all excited. We are all trying to move forward. We've had relatively good success with treatments like azacitidine and Lyridomide, but our hope is to bring many more for the patients. Thank you so much for patiently listening to me. I'm sorry I go so fast, I know.